So, what happens in some of the best clinics in the world? My colleague, Dr. Weinblatt, who works in Boston, these are data from his clinic, where he's taken patients who turn up to his hospital in Massachusetts, and many of them achieve remission. And the extraordinary thing is that by the end of 1 year, look at the number of them who continue to get remission, it plummets. So again, it's great that we've got remission, but that target is not maintained in most people. So again, it's a little bit artificial. So here's the issue. If the treat to target, actual targets themselves, if they're aspirational or unrealistic, should we actually still make use of them? So the pro of this is by striving towards a target, you try to get the best long-term outcomes and switch off inflammation as completely as you can. It's very important that your physician and your nurse measure this regularly and adjust your treatment accordingly. But the con is that where the targets are completely unattainable, some individuals might actually get very worried about this. Again, not many of you knew what your DAS was, but have any of you gone back to your physician a bit worried because actually your disease activity hasn't improved as much as you'd hoped? I wonder. Well, at least some of you nodding in the room, which is interesting. And not everyone will feel like that. Everyone's case is completely different. So another problem is if you strive for the unattainable, of course, it might make you quite depressed. So we have to do things in a way that really boosts things up, that sets a goal that's realistic for the individual and allows the best outcomes for that individual. So here are the principles again. If we look at disease activity scores measured over time, hopefully it will come down as treatment started. And we can look at the time taken to reach low disease activity, the time it takes to reach remission if you're one of the lucky ones who gets that. Or I mentioned earlier, we can look at the area under the curve, which is inflammation, and see how quickly you can actually optimize the inflammation suppression over time. And that's the goal, to switch it off as completely as we can, but recognizing that you don't want to keep on flogging the horse so hard that it actually collapses before it wins the derby. The thing is that if we give more and more treatment and it causes side effects, that's not a good thing, and we have to just make this balance, and it really needs to be done in partnership between physician and patient. So I'm giving you the doctor's viewpoint here and trying to get you to see things from the doctor's point of view, but then hopefully in discussion later there'll be more opportunities to think about it from the way you see these things. This is a complicated graph, but it's just, in a way, evidence that supports what I'm saying, that the more you switch off the area under the curve of inflammation, the total dose of inflammation, the better you do. And this is from a very famous study in Holland that shows that the vertical axis is the area under the curve, and it's showing there's a very strong relationship between the total dose of inflammation over time and the damage that can occur to joints. So it's definitely good to switch it off if you can. So when you actually ask physicians what they do, here's the answer. So about 2/3 of them actually think the treatment targets are a good idea and use them. About 2/3 actually look at the percentage improvement or absolute improvement in these scores and then adjust treatment accordingly. And when we look at the people who have persistently high disease activity, it's about 3/4, significant radiographic progression. That would means about 2/3 of the physicians would alter therapy on that basis. And when patients actually report a problem, about half of the physicians would alter the therapy on the basis of what the patient says. But my own view, for what it's worth, is you will need all these elements. You need to know what the patient thinks, what the joint scores are doing, and what the X-rays are doing, and so on. So this idea of tight control, actually one of the first tight control studies came from Glasgow, and they do a lot of good research up there. If any of you have asked a Glaswegian to buy you a drink in the bar in the evening, you'll know why it's called tight control. But the idea actually was rather different. It was in order to switch off inflammation as completely as possible for as long as possible. So having talked to you about some of the pros and cons of these targets, here are some of the issues. That if you can get the targets, you preserve function over time, you keep people in employment, which is good, and you prevent some of the complications of rheumatoid that maybe some of you know about from first-hand experience. So that's the good side of it. However, now it's become apparent that we've got drugs that can give rise to remission in a minority. People get more and more ambitious. Doctors get ambitious. They say, well, what do we really mean by remission? Does it must mean that when we look at you, you've got no inflammation? Or does it mean when we put our ultrasound probe on your joint, we can't see any inflammation? And so the goals get more and more ambitious as we go up the scale. We've changed the height of the bar. And so we're trying to jump a higher hurdle. And there are some problems about this. So the groups called ACR and EULAR have actually looked at the definition of remission, and they've described this, and there are various ways of describing it, but you can do this on the basis of the number of swollen joint counts and tender joint counts and the patient global, all the things we were talking about earlier. And in clinical practice, these are the ones we do, so don't worry about the terminology. But basically, it just means adding up the numbers of tender joints, swollen joints, and the patient global assessment. And these graphs are a bit complicated, but we're treating you as doctors today, so you can see it from the doctor's point of view. What this is showing us, if you compare the normal healthy population, these are the old way on the left over there of looking at remission. And the healthy patient population, so if you take people who don't have rheumatoid, have the same age as people who do have rheumatoid, you'll notice that actually the remission for healthies and normals, the blue line and the grey line, overlie each other. Okay, so you'd be as a healthy person of the same age. But if you look at the more stringent criteria that have just been produced by the committees to define remission, the amazing thing is that a rheumatoid patient in remission is even healthier, supposedly, than a normal person who doesn't have arthritis. Is this sensible? Well, if we had drugs that turned us all into Superman, that would be great. But we don't. And so if we go on giving more and more drug and more cost and getting side effects of drugs, that doesn't seem to me to be entirely sensible. So on the one hand, I'm not trying to say we shouldn't try and get patients into remission, but we do need to use these drugs sensibly and wisely. So if you move the goalposts, the question is what proportion of patients will actually achieve these targets? And that's what's happened. All these committees have really thought about it from a doctor's point of view. Wouldn't it be great if all our patients do brilliantly? Well, of course it would. But they've moved the goalposts. And what happens? Well, here's the answer. This is the proportion of patients who actually get into remission. It's less than 10%. In fact, it's about 1 in 20, 1 in 18, based on these new remission criteria. If you use the old DAS criteria, it's 1 in 5 patients, and there's another type of criteria for remission where, again, it's about 1 in 18, 1 in 19, something like that. So these are challenging targets, and so it's good to have aspirations, but we have to recognise they are aspirational. And if we look at the Canadian experience in arthritis and the numbers of patients who achieve these, if you look at the old DAS28 targets in early arthritis, half of them will achieve it, but if you look at these new ones, only 1 in 5 will. So really these are not entirely sensible targets. So we do have a problem. If we look with another drug, this is an anti-IL-6 drug, so some of you might be on a drug called TAMARA perhaps. This is the proportion of patients who achieve these different remission criteria here. So you can see, depending on the dose of drug and the time, you might get up 1 in 5 patients achieving it. So it's good to go for gold, but not everybody's going to achieve gold. So what is the case against these bureaucratically set targets? Well, they are largely aspirational, particularly if you've had rheumatoid for a long time. And in long-established disease, actually the major personal goals may be completely independent of all this, and we'll illustrate that with some cases in a minute. And if you fail to meet your target, of course, it might make you feel a bit despondent. So there's a lot of good news here that we haven't come on to yet, you'll be pleased to hear. But there's also some not so good news. Now, I believe as we look around us, we're in a very unusual environment, and so there's a little touch of Zen in this room, I believe. And this quote, which is actually from Shakespeare, no less, I think is there's deep wisdom in this. But nothing is either good or bad, but thinking makes it so. It's how we look on it and think about it that actually determines whether or not it's good or bad, just by a mental construct. But the same is true about these targets. They're not intrinsically good or intrinsically bad, but they can be wrongly used. And if we become solely fixed on treating a number, we don't treat individuals. So we need to set realistic treatment targets, and it may well be that moderate disease activity, which is what MDA stands for, is a much better goal for most people. We should certainly try for remission if we can get there, but recognising most won't achieve it. So, what do we go for? If you actually exclude the pain element, in fact, you'll find that many more patients will actually achieve moderate disease activity, which is interesting because pain is often one of the features that doesn't switch off as well with the drugs that we have at the present time, as many of you will know through experience. So when actually should we make a decision to change treatment? And you might ask what's happened to you in your experience. If you're on an anti-TNF and you achieve the target within 3 months, that's fine. But if you don't, the idea is you change your treatment and have an alternative anti-TNF or another biologic. I wonder how many of you recognise that from personal experience. And then if you achieve this target that we've been talking about, that's fine, and you carry on with treatment. But if you don't, you go around the cycle again, try something different. The only trouble is, of course, that if you try something different, your local commissioner may not give funding for what you apparently failed the first time. Don't forget that. So if we look at the Dutch data from Dutch clinical trials, they asked these sorts of questions. And what they found was that if you waited 6 months, that more and more patients will hit some sort of response. About 2/3 of patients will get a response by 6 months, which is very good. But if you only wait 3 months, you find that just under 2/3 will achieve it, but it's not far off. But look at this figure. If you wait a full 6 months before working out whether a patient has actually responded to their drug, the penalty you pay is that actually twice the number will have failed on the drug that time. So all these patients who don't respond after they've been on the drug for 6 months, the cost of that is £5,000 each patient. And in a cash-strapped NHS, this is really an issue. So maybe instead of getting all this loss, we could halve the loss just by assessing people's response at 3 months and see whether the drug's working, and if it's not working, we'd change it. But it's not always so straightforward to know if it's working, because these targets set very, very high levels of improvement. So if you have a partial improvement, like the people on the left, maybe you carry on with your drug. So in other words, you haven't hit the remission target, but you've got some degree of improvement. You go on and see if the improvement continues to go up over time. Whereas if you've got no clinical response at 3 months, then actually you change treatment because the patient's unlikely to achieve any of the goals. So here's another quote I like from a very famous rheumatologist, actually. He was a Canadian, and you can see he worked in an era long before contemporary drugs, that he said, "The good physician treats the disease, the great physician treats the patient who has the disease." And so here are the issues. That in order to maximise quality of life, which might be for any one of you, the way the doctor will think about it is controlling the symptoms, preventing the damage to joints, and that is done by optimally controlling the inflammation. That's what Treat to Target is all about. And that, in turn, one hopes will keep your function normal, and that will allow social participation and integration in community and leisure activities that you enjoy. But what about the people who don't actually achieve remission? Well, here again, we want to control symptoms as well as we can, limit damage, and again, control inflammation as far as we can. But there may be some physical and psychological functioning that needs to be addressed. There may be family issues. Many of you will have loved ones who wonder what they can do to help you if you have rheumatoid. It's not easy, as you know very well. And then there are your life plans and aspirations. And that's when we need a multidisciplinary approach and a holistic approach to address that, not just treat the figures alone. We need to treat people. So just let me quickly take you through a case the way a doctor might think about it and see if this sounds familiar to any of you. Supposing you're 48, you've had rheumatoid for a couple of years, and the doctor sees you for the first time with active rheumatoid, and previously you've been seen at another clinic. And you're on methotrexate as much as you can tolerate, 17.5 milligrams once a week, and on hydroxychloroquine a couple of times a day. And your DAS28, your disease activity, is 5.4, which is high. So this patient's in trouble, they're not doing well. So how do you think the doctor will treat her? Do you think he or she will try and escalate their methotrexate? Anybody think they might do that? If it's one of you, is that what your doctor would do? Tell me how many. Just stick your hand up if your doctor would do this. Okay, one of you, doctor, will do that. Would any of them give you steroid, give you a jab in the bottom, perhaps? Quite a few of you. Would any of them start an anti-TNF if they didn't think there was... So few of you would have had anti-TNF, yeah? Would any of them give you a different biologic therapy, not an anti-TNF? They might do, because now NICE will allow that under certain circumstances. Maybe they'd have added in sulfasalazine. Does that sound familiar to any of you? Yeah, a few of you. Okay, quite a lot of you have had. So all of you have experienced these different options. Well, I'll tell you what actually happened here. She actually started an anti-TNF because she met the guidelines. There was no reason not to. And she was assessed at 3 months, as you're supposed to by guidelines. And in fact, her DAS had improved, but only by 0.8. This is where guidelines begin to get a little bit tricky, because guidelines are only to point us in the right direction. So would you again try and increase the methotrexate, give her a steroid or whatever? And there are all these options. Well, in fact, what happened with this particular lady is that we just carried on and waited a bit, and she did brilliantly. But had we not waited, she might have lost that chance, and what's more, had we tried to give the biologic again in the future, we might have been told, no, you can't have funding for that, she's a failure. So all I'm pointing out is that guidelines are good, they can make us aspire to more, but they can also backfire if they're not used wisely. So the physicians have to think about these things, and it's really good when they can do that in partnership with patients. Now, I'm going to show you another case which might look a little bit familiar to you, and now we've been through the first one, you'll all know the answers to what to do. So here's a lady who's had rheumatoid for 2 years. She sees you for the first time, you're the doctor, sees you for the first time, she's been seen elsewhere, and she's got active disease with a DAS28 of 5.4, she's on the same dose of methotrexate and on hydroxychloroquine. What are you going to do? So you're the doctor this time. Now, how many of you are going to do something, but I've left out a little detail. This time, instead of being 48, she's 84. So does that make you think differently? What do the guidelines tell us? The guidelines don't tell us anything about age. Guidelines say we should do the same in everybody. Is that sensible? Well, how many of you would try and increase her methotrexate? Nobody. How many of you would give her a jab of steroid? A few of you would. There we are. You see good budding doctors here. How many of you would start her on anti-TNF? Okay, so quite a few of you would do that too. Would any of you give her a different biologic? No? Any of you give her sulfasalazine? Perhaps those of you who've experienced it, not many. Well, most of you said steroid or anti-TNF. Well, this is what actually happened. But the thing is, here's a bit more of the story I haven't told you. So this poor lady who's 84 is housebound. She's had carers 3 times a day. She can't really get out of bed properly. She sits. And what she really wants to do is to be able to cook independently and not have the carer give her some ghastly ready meal she doesn't want, just now and then. And I ought to emphasise, I'm sure she's very grateful for good carers, as many of us have been grateful for their attentions. But just to illustrate the point that the needs of the individual need to be married to their personal circumstance, and that's obvious. But sometimes guidelines don't give you those pointers very accurately. So the question is, what should we do for this lady? I'll tell you what we did do. We actually gave her an anti-TNF, and this is what happened. So we gave her anti-TNF, and she was assessed at 3 months. And this is what we found. Her DAS28 had gone up by a little bit, it's 5.6. Well, in fact, her DAS28 got, but there's a caveat here, and here's the caveat. She actually feels fantastic. She's not tired. She can mobilise better. She's cooking lunch for herself 3 or 4 days a week, and she really loves being on this drug. And so what is the physician going to do if we follow the guidelines? What do you do? This is the moral and ethical problem. The point I'm trying to make is that guidelines are good as far as they go, but they're not always going to give you the right decision for the right individual. And that can only be done well when the patient and the physician work in partnership and there are good lines of communication open. And the same is true for all the helplines and help that I know you get from your colleagues at NRAS. So here's Christopher Columbus looking to the future. In the last few minutes, I'm going to look to the future with you because here are some signatures which are psychometric and written. So this is actually Christopher Columbus's signature. And it's quite interesting, actually. So he signed himself. These little letters stood for the following. Christophorans, he called himself the Christ bearer. He saw himself as a religious zealot in a way, going to found a new world and take his beliefs elsewhere. So he called himself servant of the Most High, Saviour, Christ, the Son of Mary. Although, again, the Hispanics actually think the world of Christopher Columbus. He founded a new nation. But at the same time, I think there were some less fortunate things that happened on the way. So it's an interesting piece of history and set in the social context of the time. So that's over 500 years ago. But let's come on to another signature for the last few moments now, and just talk to you about a tool we're working on in a research project. We've been very fortunate that we've had help and advice from Elsa and some of the others of you in this room that have looked at this with us, and it's a work in progress, it's not finished. But we are using a tool in the clinic where we have an iPad which we give to patients in the outpatients. There's a video on the iPad that gives instructions, so there's no bias coming from someone talking to the patient. And we say, this is your life at the moment, if you imagine the white on the iPad, and that yellow bit there is yourself, it's you, the patient. Then we take a disc which in fact is more red colour than that sort of orange, but we call it your illness. So in this case, for most of you, it would be rheumatoid, if you have rheumatoid. And we say you'd put the illness on the board as it affects your sense of self, your life, your personhood at the moment. So if someone puts their illness right on top of their sense of self, they're suffering a lot, it's really infecting them. Whereas if they keep it quite a way away, they may be doing very well on medication, for example. So that distance between the two is the so-called self-illness separation. It gives an idea of how well or badly the patient is doing. And now, again, I don't want to bamboozle you with science, but we can look at this much more sophisticated way as well. We can look at the angles. Now, let me just take you through this. Supposing, I'm going to step up here, I hope I don't knock it all over. No, so far so good. So let's supposing a patient puts their disc here, which would mean they're suffering a lot and doing really badly. And I were to say to them, if you were to take a target that really matters to you, what would you like to do with a therapy you think would be worthwhile, and you get a degree of improvement that's worthwhile for you, where would you move it? The patient might move it, let's say, to here. Okay? Let's see, if I get that much improvement, I'd be quite pleased. And so that gives me an idea. But you'll notice that if they move it anywhere along that line, actually, they'd be similarly pleased. The patient who moves in this line has all that way to improve, whereas the patient who puts the disc here, it's only got a little way. This person's a little bit pessimistic, this person's much more optimistic, because they've got a bigger scope for improvement. So we can begin to tell something about the psychology of the patient just by where they put the disc. But that's not really good enough, because if we really want to get personalised goals that matter to you, we need to know what's important in your lives. So here's the illness disc. This particular person's suffering a lot because it's right on top of their cell. We ask people to choose 5 aspects in their life that matter to them. Most people will choose relationships, such as a spouse, their work, and their friends, and various other things. So we choose usually a minimum of 5, but we could use up to 10 or so, and completely personalise this to the needs of the individual. For the elderly lady we talked about before, it might be cooking a meal. And here's an example of a chap with rheumatoid. So he's 44, he's got seropositive rheumatoid arthritis, he's had it for a few years, he doesn't have any children, he was a salesman, and he's on methotrexate and diclofenac, so that's Voltarol. He has quite a bad disease activity index, but on the other hand, his HAQ score, which is a measure of function, is not too bad, it's pretty good. But he's very depressed, as you can see. And this is what he does. He puts his rheumatoid quite close to himself, so he sees it as a big problem. And he considers himself very disabled from his rheumatoid. He's always got pain. It reminds him of his illness. And he sees himself as being a completely different person from the one he was prior to getting rheumatoid. Some of you may find that familiar. And this is how he ranks the things that were important to him. His family and friends are still quite close to his sense of self, which is good. He would love to ride his motorbike, which is a long way away. That's his passion in life. He can still manage self-care, but with some difficulty, and he can still work. Now, his wife, many of you in this room might have spouses or loved ones who try and help you out. And I won't embarrass you by asking if you always think their advice is wonderfully helpful. But actually, it's incredibly difficult to be married or in a relationship with someone who has a condition, because often you're quite impotent in terms of helping. It's not easy to know what to do. So Mr. R's wife wants to help him, so she suggested he should go out for a walk each day. It doesn't look too bad. He should go out and get some exercise, get a bit fitter. But in fact, his view about it is that he can't keep up with her. So he feels upset, it makes him feel inadequate, and he's quite depressed about it. These are simple things, but that's how life is for many of us. So some of you might resonate with this. What he really wants to do, doesn't want to let on to his good lady, is to get on his bike. So he wants to ride his Harley Davidson, and actually for him that was the thing that would really boost his confidence and make life worthwhile again. That may sound bad in some ways, but that's what he said. So this is what happens after treatment, and this is very gratifying. So here, his DAS28 hasn't done wonderfully. He hasn't gone into remission. And so for all the measures in the guidelines, this chap would have done really badly. But look what's happened in real life. His rheumatoids moved right away. It's no longer impacting on his sense of self. His family and friends are closer to him. He feels part of the family, he can actually engage with them now. And look where his motorbike is with his real passion. He can ride his bike again. So for him, we've captured a measure here. So all this can be quantified, it can be written down. The managers are happy because they've actually got a figure that they can then measure on their books and commission things. This is part of the problem of the contemporary world in the NHS. Things have to be commissioned to targets, and whilst we all understand that, they don't always align to personal needs. So here's a tool that might perhaps allow us to personalise the needs of the individual in a way that can be quantified and therefore be more accepted and give a more realistic goal setting. And this just gives some figures for how this chap improved. So in conclusion, I've talked far too much, I'm sure, but the points really I wanted to make is that this whole treat to target evolution that's come about in the last few years really has enormous value in terms of switching off inflammation, which is very good and very important, and making sure we get the best use out of the medication we have. But it also has a downside in so much that the targets that are chosen are not entirely realistic and can be used both against you as well as for you. And therefore we need to develop some new measures and not solely focus on measures of disease activity at the expense of addressing the needs of the whole person. At least that's my view, but you'll have your own views about this, and it's only by sharing them, and there'll be opportunities later today, I think, to do that, that we can really work on this sort of thing together. So here's a little epilogue. There's Christopher Columbus discovering the New World, happened 500 odd years ago tomorrow, but the heritage of the past really shapes future development, and one of the many things for which I can only take my hat off to Elsa and all our friends and colleagues in NRAS is it's by your proactive involvement with physicians and policy makers that you've really helped generate guidelines that have meant that the outlook for any of you now is so much better than it was a decade ago, 11 years since your own birthday of NRAS. But we've still got a long way to go, and it will be by working together with you and by clinical researchers like me who can work alongside you that I hope we can set our sights at greater things still, eventually to make sure future generations won't even get this condition. So in 1492, Columbus sailed the ocean blue, you will remember the rhyme, discovered the Americas, and tomorrow, and indeed here at this meeting today, we raise awareness of unmet need on World Arthritis Day and really set our sights on future therapeutic advance that I hope will see the end of this dreadful condition in the next few generations to come. So thanks ever so much for staying awake and putting yourself in the doctor's shoes, and you all deserve a cup of tea or coffee.